Hi, and welcome to Postpartum and Complications. Today we're going to discuss some maternal physiological changes in the postpartum period, the bubble HE assessment, postpartum readjustment, postpartum hemorrhage, thromboembolic disease, a few postpartum infections, and some postpartum psychiatric complications. So what are the main physiological changes that occur? What we're looking at primarily is the uterine changes. That's what we are most able to physically assess, and it's going to be what potentially causes our most relevant problems. So what is involution? Involution is the process of the uterus returning to the pre-pregnancy state. So you can see here that the uterus right after birth starts at about the umbilicus, and then it continues on down. And by day 9 postpartum, it should be almost back to its normal state. As the changes of the uterus growing are associated with centimeters above the pubic bone, the same thing is accurate for postpartum days. So it should be below, so it goes down 1 centimeter each day. So it's kind of interesting that we're able to significantly track how the fetus is growing by centimeters of growth of the fundus, and then how mom's postpartum recovery is going by the involution process, going centimeters down. Subinvolution occurs when the uterus fails to return to the pre-pregnancy state. This can be caused by retained placenta, retained membrane infections, a full bladder. Sorry. So we want to be vigilant in our postpartum assessment and always making sure that the uterus is actually going through the process of involution and doesn't go backwards. If it goes backwards, then we need to be concerned. So if I was at the U-3 on postpartum day 2, and then the nurse came and checked, and now I'm at the U, there's a problem. After pains are continued uterine contractions. We have the uterus continues to contract down, which is the process of involution, and after pains occur more readily when baby is breastfeeding. So those moms who breastfeed their little babies are going to have an easier recovery because they have the additional release of oxytocin during nursing that helps the process of involution. And the cramps that are occurring with that are called after pains. Unfortunately, after pains get more intense with each subsequent pregnancy. So they might not be too bad with baby number 1. By baby number 4, you feel like you're in labor when you nurse your baby. And we want to relay that to the moms and recommend ibuprofen for pain relief. With the process of involution, we also have the continued shedding of the uterine layers and the processing of the blood that was in the uterus and the process of regrowth for the uterine lining. So we're going to see rubra, which is blood and debris, and it usually lasts for the first 3 to 7 or so days. Then it's going to become a little bit less red and a little bit more pink. We call this one serosa. and it usually lasts until about 27 days after delivery. It's usually, or it consists of old blood, serum, leukocytes, and various debris. ALBA will continue until about 6 weeks after birth, which is leukocytes, mucus, serum, and bacteria that's being excreted. Keep in mind that these are generalizations for the time frames and that every woman is going to be a little bit different. What we really want to communicate to mom is that it is of utmost importance for her to seek help if she is saturating a pad in an hour. So if she's bleeding so much that she saturates a pad in an hour, or if she passes clots that are bigger than the size of like a quarter or potentially even a golf ball, then she needs to be alerting somebody of that as well. She might see a recurrence of bleeding 1 to 2 weeks after birth, and this is the healing of the placenta site. So if at day 4 she's kind of seeing the rubra turn into serosa, somewhere between 1 and 2 weeks she might experience significant bleeding again from the healing of the placenta site. The other concept that we want mom to go home understanding that if she has an increase in bleeding after bleeding has subsided, that we want to hear from her about that. And yes, we will hear from a lot of people who are experiencing their placenta site bleeding, but we will also catch those who are experiencing some sort of postpartum hemorrhage or have an infection or something like that as well. So here's a good visualization of how we're going to rub the fundus. You can see here that the hand is at the fundus and pushing down, and you can see the hand here, and they're better in these pictures, the bottom hand and the top hand. The bottom hand is supporting, sorry about that, is supporting the lower uterine segment because we don't want to prolapse that uterus, and the top hand is making sure that the fundus is where it's supposed to be and that it's nice and firm. So this picture here is about 2 hours after birth. This is about 2 days after birth, and this is 4 days after birth. And we talked about the lochia. So how we document lochia and communicate about the amount of lochia is by scant, light, moderate, or heavy. And you can see here what the different amounts translates to visually on a peri pad. So some of the other physiological changes that we're going to be dealing with in the immediate postpartum period in the hospital is we might have some soreness from being in the lithotomy position for pushing and for the episiotomy laceration repair. Sometimes those hip flexor muscles become very sore because the legs are up and being pushed back and mom's pulling them back. So we're going to have some musculoskeletal soreness. And hopefully we don't have any injuries. Every once in a while, unfortunately, we do get an injury. But hopefully it's just kind of musculoskeletal soreness that we're dealing with. We're going to potentially have some hemorrhoids. Pushing a baby out is serious business and sometimes causes the prolapse of those little vessels around the anus. And so we're going to assess the amount of hemorrhoids. If it's just a small amount and they're not bulging and not bleeding significantly, then it's probably just going to be a time situation. We're going to provide mom with some witch hazel pads, which are going to be very comforting to her, and we're going to suggest sitz baths. And sitz baths can be purchased at most like Whole Food stores, like a Fraser Farms, a Sprouts, a Whole Foods, a Boney's, whatever might be in their area, or at a medical supply store. And the sitz baths are really going to help to keep the area clean and to relieve some of the discomfort of hemorrhoids. Hemorrhoids can be painful and can be itchy, so they're incredibly uncomfortable. We want to help mom to be as comfortable as possible in as many of the areas as we can, because she is dealing with so much with having a newborn baby as well. There also is potential for surgical treatment, if the hemorrhoids are severe and significant. And that's an assessment to be done by the provider, but we can, if they look significant, then we can suggest that the provider check them out and assess for potential surgical interventions. Kegel exercises are going to be really important for the return of the pelvic floor muscles and to prevent urinary leakage. So the area, when the baby is born, there's a lot of trauma that occurs in and around the perineal area. So ensuring that that muscle is as strong as possible is really going to help. We're actually going to be suggesting prenatally that women start doing Kegel exercises to really strengthen that pelvic floor muscle, and that will really help them actually push their baby out, because they'll have a better understanding of where they need to push if they've been doing their Kegel exercises, and more strength in the area. Postpartum diuresis occurs from decreasing estrogen because there's no more placenta. And that we also typically have an excess of extracellular fluid that accumulates during pregnancy and during the labor process. Remember, mom has 50% more blood volume during pregnancy than in her pre-pregnancy state. So all of that volume has to go somewhere. Mom typically diureses at night. She'll experience significant diaphoresis probably around the second night, and it's totally normal for her to wake up in a completely soaked gown. We want to feed mom after birth. She's going to be incredibly hungry. She has most likely not eaten for however long her labor was, and she just went through an incredibly physically demanding and physically taxing experience. So she's going to be hungry, and we want to make sure we provide her that food. Bowels, we might not see a bowel movement for the first couple days after birth. Mostly it's due to not eating. Also, the bowels were probably significantly evacuated during the birth process, because the baby's head pushing on the rectum is going to push out all of the bowel or all of the fecal matter that's in there. So it's okay if she doesn't have a bowel movement. We also might see that she had pre-labor diarrhea. That's very, very normal due to the decreased muscle tone during labor. So we might see the mom has truly evacuated all of her bowels while having the baby, and then didn't eat for a couple days in labor. So it might be a couple days before she has another bowel movement. We are, however, going to suggest that she takes a stool softener for the first couple weeks postpartum, just something over the counter like Colace, and not something that's going to force her to go. And I'm sorry, the word is escaping me right now, but we want just to make things softer so that she can go without pushing too hard. We don't want to cause additional trauma to the area. From a breast perspective, we're looking at colostrum for the first 24 hours to 3 days, and then the milk starts to come in at approximately 3 days. She might see some significant engorgement when that milk comes in, and it might be painful, it might not. It just kind of varies per individual. We can suggest just some warm showers, and feeding her baby frequently will really help with that. She can do cold compresses to decrease the engorgement because it has to do with inflammation of the lymph tissue. It usually goes away about 24 to 48 hours after that milk comes in, though. So we can rest assured, or let mom rest assured, that it won't last too long. The integumentary changes that we see is we might, if mom had the chloasma of pregnancy, we will see that disappear. Linea nigra and some other pigmentations such as the striae of pregnancy, so stretch marks, those might not completely disappear. And we want to warn moms who have babies with billy blankets that if they keep the billy blanket on their tummy and their baby on their tummy, it's going to take significantly longer for that linea nigra to go away, because the hyperpigmentation that's there kind of gets, you're almost like tanning it in, you're locking it into that area. So they might not disappear completely, or it's going to take a long time for those changes to go away. But the chloasma should go away pretty quickly after having the baby. Cardiovascular changes. So mom's going to return to her pre-pregnancy state. Estimated blood volume loss for pregnancy is between 2 to 300 for vaginal birth and 1,000 or so for a C-section. The C-section loss of blood volume is going to constitute about 15 to 30% of the blood volume. But remember, mom was up 50%, so her body was meant to do this. Cardiac output is going to increase for the first 48 hours postpartum, and then it's going to decrease by about 30% at 2 weeks. And then usually normalizes at about 6 to 12 weeks postpartum. From a vital sign perspective, we're going to see heart rate and blood pressure normalize within the first few days, and respiratory rate will normalize soon after delivery if it was elevated. Her H&H is going to decline by 16%, the normal pre-pregnancy state after birth, but it will return to normal by about 8 weeks. We might see an increase in white blood cells. About 10 to 12 days after childbirth, we might see 20 to 25 for white blood cells. So this can complicate matters if there is an infection present, because we might think it's just a normal rise, postpartum rise in white blood cells. So we need to be vigilant about assessing for some of the other signs and symptoms of infections and not just rely upon our lab values. From a coagulation perspective, mom's going to experience an increase in fibrinolytic activity 1 to 4 days after delivery. Her clotting factors and fibrinogen remain increased for those few days. Because of that, she is at an increased risk for DVTs and other thrombolytic issues. I am going to provide you a note sheet that has some other physiological changes that occur postpartum for you to look at. It will be testable material. It's very word heavy, so it will be better provided in a note sheet than in a lecture, and we can go over it in our in-person lecture. So for the bubble heat assessment, this is our postpartum focused assessment. And we've gone over this a few times. We've done it in our survival skills lecture, but we're going to re-review it. So We're going to start with the breasts. We're going to assess the breasts and look at them and make sure they're symmetrical, that there's no redness, no nipple trauma, and it's also an opportunity for us to assess for any lumps that might indicate the need for further assessment. We're going to educate mom about the engorgement that she can expect those few days after her milk gets in. And we're going to talk to her if she isn't planning to breastfeed on how to suppress her milk. She can use a breast binder. She'll want to use a well-supportive bra, but without any underwire, because the underwire can really pinch and cause further complications for the breast. She can apply ice packs, use cabbage leaves, and the most important aspect of it is that we do not want her to stimulate the breasts. So although she might become engorged with milk, we do not want her to express any of that milk, because remember, milk is supply and demand. It will take a few days to a week for the production to cease. For engorgement, we want to suggest a good fitting supportive bra, again, without underwire. We're going to suggest a Lancino cream for any cracking, soreness, bruising, or blisters. Or the other option is to have mom express some breast milk and apply the breast milk to those areas. The antimicrobial properties of the breast milk will be really helpful. When we assess the uterus, we are doing that fundal rub that we looked at earlier, and we're assessing for atony. Remember, this is an assessment in the initial postpartum period while mom's still in the hospital with us. So we're going to rub her tummy and make sure that that uterus is firm and that it's involuting. So it's going through the process of involution and moving on down past the umbilicus, and that her bleeding upon massage is not too bad. If we have uterine atony, so if our uterus, instead of feeling almost like a rock in her tummy, if it feels soft and squishy, we're going to rub. The best initial intervention is massage. So we're going to massage the uterus, which will hopefully help that uterus to firm up. We're going to assess her bladder and make sure that her bladder is empty, that she's able to urinate. We're going to measure her first couple outputs to make sure that she has adequate output and no urinary retention. Keep in mind that a full bladder can cause or can prevent the process of involution from successfully occurring, and we might see subinvolution and an increase in bleeding. For the bowels, we're going to provide her with the stool softener. We want to know when her last bowel movement was, and we're going to assess for hemorrhoids. Lochia we talked about earlier, so we're going to take a look when we rub the fundus and see what is being discharged and how much lochia there is, and we're going to utilize our the visualization of the pad to document how much lochia there was. Homan sign and clonus, and then ambulation. So this is our H. Homan sign, we really want to assess for DVT. We're going to take a look at her legs, make sure there's no warm spots, no red spots, particularly in her calf area, and we can perform Homan sign and have her lift her foot back and see if she has any pain. We'll assess clonus at this point too, particularly for our patients who were had a diagnosis of pregnancy-induced hypertension or have a diagnosis of preeclampsia, eclampsia, or were on mag sulfate for any reason. We're going to want to assess their clonus as well. We're going to tell all moms to call for help for the first couple times they get up to walk, even if it's just to the bathroom. They might experience orthostatic hypotension, or their legs might not be fully functioning after the epidural. So we really want to make sure that we are providing them help with ambulation. We're going to give them the non-slip socks that the hospitals have so they don't slip and fall. We might offer mom TED hose or STDs if she's at an increased risk for a DVT for any reason. And then emotions. We're going to assess her emotions. We're going to help provide comfort. So we might provide her a heating pad. Motrin actually kind of falls under emotions, because if you are in pain, even if it's kind of a mild pain, you're still going to become irritable. You have our ice, warm blankets, the witch hazel pads that I mentioned earlier, and the sitz bath. And we really want to help these moms to sleep. They're up with their newborn whenever that baby needs them. So as a postpartum nurse, we are going to be extra cognizant of clustering our care, ensuring we're not interrupting her unless we need to. We're also going to discuss her emotions. So we'll talk about postpartum depression and baby blues and postpartum psychosis a little bit more in depth later in the lecture. But in our assessment, we want to provide her education about those aspects of emotional self-care and make sure she knows that there is help if she's not, if she's feeling depressed or feeling down, that she needs to talk to somebody. And when we have these discussions, we want to ensure that somebody else is in the room with her. Hopefully it's who she's going to go home with, but we want somebody else to hear it so that they can see the warning signs too. So some other aspects that we're going to look at have to do with safety, which is going to include the ID bands. So all hospitals will band mom, dad, or whoever mom designates as the other banded individual, and baby typically gets 2 bands. Some places do both on their feet, some places do one on a hand, one on a foot. It just depends. We might also have a some sort of electronic monitoring device or a hugs tag, baby low jack, something like that on the baby, which would set off an alarm if the baby was taken from or taken outside that locked unit area. We're going to check those ID bands every time the baby transfers somewhere or every time the nursing care changes. And this is just to ensure that we don't switch anybody's babies. We want to make sure that the crib is away from the door, and we're going to follow all infant abduction protocols. So it's important for us to know what the codes are and where to go if there is a code called that indicates an infant abduction. Sorry. Infection control. Remember, babies are born with very, very little immunity. So we need to be extra vigilant about washing hands and making sure that if you're sick, you don't come to work. That goes for you in the clinical situation as well. These little newborns just don't have enough of an immune system to fight things off. So we're going to wash our hands, make sure we're following any precautions that might be necessary, and take care of yourself so you don't get sick. If you are sick, stay home. Couplet care is the term that's utilized for postpartum care. And that means that the nurse is taking care of both mom and the baby in the same room. Remember, most of the time, we have a very healthy mom, and we need to include her and the family in the care of this baby, because in a few hours, they're going to be taking this kiddo home on their own, and they're going to have to do everything. Subsequent parents, so second time on moms and dads, typically care for their own babies just innately. It's just they've been through this. They have a baby at home. They've already done it. They're going to take care of their kid. First time moms and dads aren't really sure what they're supposed to do compared to what the nurse is supposed to do. So we need to have a little bit more patience with them and make sure that we are communicating clear expectations. I usually say, this is your baby. I want you to do as much as you are comfortable doing. If you need help with anything, I am here for you and more than happy to go through it with you. And then I just really make them do it instead of just watching, like, okay, Dad, come here. I'm going to walk you through putting the diaper on. Or, okay, Mom, let's go ahead and swaddle the baby. So we'll lay the baby in between her legs on the blanket and let her swaddle the baby. For vaccinations, these refer to vaccinations for mom. So if she is not immune to rubella, we're going to definitely offer that rubella vaccine, because remember, that can cause significant fetal development issues if rubella is present during the fetal period. So we want to provide the rubella vaccine, varicella, Tdap, flu if it's flu season. We have her here in the hospital. Let's just get her vaccinated for what we can do. We're not going to give rubella during pregnancy because it's a live virus and it can cause defects. Varicella, when we give varicella, we're going to advise that they don't conceive a baby for the first month, which is usually pretty easy to do since she probably isn't able to do that. And then Tdap is so important because of the increase in pertussis. So we're making sure that families who are taking home babies are vaccinated with Tdap. RhoGAM, we give RhoGAM in the antepartum or in the pregnancy state, prenatally, at 28 weeks, or if there's any trauma. And then we're going to give it within 72 hours after giving birth if the baby's blood type or if the baby's Rh factor is actually a negative. If the mom is Rh negative and baby's Rh negative, then we don't need to give the RhoGAM. A lot of postpartum is teaching, and so we need to make sure that we're addressing all of the needs of that mom and that baby so that they can go home and be successful. Your book has a great informational box. It should be box 14-3 that shows all of the criteria. Some things that moms might ask about would be birth control. They can talk to their provider about that. If mom is breastfeeding, we don't want her to rely on that for birth control. Now, there's a caveat to that, to where it is actually just as effective as any other form of birth control if mom is co-sleeping with the baby, which means baby's in the room with mom at night, and mom is feeding on demand. As soon as mom pumps or misses one feeding that, for whatever reason, it's no longer an effective form of birth control. And that's why we don't want moms to rely on it as birth control. So a well-educated individual might be able to understand that it's not something that we want them thinking, oh, just because I'm breastfeeding I can't get pregnant, because that is not the case. Women can definitely get pregnant from breastfeeding. And remember, ovulation occurs before the period occurs. So she's going to ovulate before she knows she's ovulating. We want to provide as much education and resources too as possible. So we're going to let her know that we might provide a follow-up with home health, which is always great if home health can go. In San Diego, we have First 5 of San Diego, which is a great organization that will help moms in the postpartum period. There's Warm Lines, which will help with breastfeeding support, and there's support groups. Every hospital and birth center in the area has support groups, and I always highly suggest that my moms find a support group of some sort that they relate to and go, just because, one, it gets them out of the house, two, it gets them mingling with people in somewhat of the same stage of baby rearing, and three, it allows them to talk to people about the problems that they're having, because it's not easy, and we don't want women to feel alone, because every mom is going through somewhat to some degree of the same thing. So when they realize that, it's a little bit easier to cope. So when we look at postpartum and we're talking about the readjustment period, we're going to think about their birth experience. So mom had an idea of what birth looked like and what her birth was going to be. Now, it may have occurred that way, it may not have, and she's going to need to process that. The birth experience has a drastic impact on mom and her view of herself in the postpartum period, and her ability to successfully move through the postpartum period without postpartum depression. So if a mom wanted a natural childbirth with no epidural, no Pitocin, in a tub, and she ended up with a C-section, intubated because she didn't have that epidural, and under general, she is going to have some significant challenges to deal with in bringing together what she wanted to happen compared to what did happen. So we want to let her tell her birth story and encourage her to talk about it and give her the reasons why what happened. And she might not accept them. She might, but at least it's there for her to pull from when she's ready to. And again, it's really important for moms to be able to tell their birth story. She's probably not going to be too pleased with how she looks after delivery. You might hear some negative self-talk, like I look horrible, I'm so fat, look at my stretch marks, all this stuff. So things that we find very beautiful in pregnancy, mom is going to think of negatively post-pregnancy in a postpartum period. There's always an adjustment to parenthood. So for those first-time moms, it's a significant adjustment. You go from being able to do what you want when you want, for the most part, to being completely at the whim and will of a newborn baby who has no idea what he or she wants. So there's a huge adjustment. There's lack of sleep. There's pain that she's dealing with in that initial period. And being a parent is probably the most difficult job that anybody will ever do. It's incredibly rewarding as well, but there is a huge adjustment period that goes along with that. The attachment and bonding of the mom and the baby is important to make sure that mom is going to provide the best care for that baby. So we want mom to love and accept the baby. We want the parent and the child to bond. And the most important aspect of this is that skin to skin after delivery. So when we're able to do that, the mom and the baby have significantly increased bonding, and mom has more positive feelings towards the baby. So when mom and baby are able to make eye contact, so we want to make sure that baby is up towards mom and in face position, and that dad gets in there too and is up close to the baby. The biorhythmicity refers to what was going on in utero. So the fetus was in tune with the mother's heartbeat and was very soothing to the fetus. So having that baby lay on mom's chest is going to help to soothe the baby. And then with synchrony, we want mom to find a fit to her responses to the baby. So, for instance, if the baby is crying and there's different cries that the baby might have for a wet diaper, for hunger, for discomfort, then we want mom to figure out what those are and be able to provide that for the baby. And then we also want the cues to be responded to. So we want to educate about early feeding cues as opposed to late feeding cues. By the time the baby's crying, that baby has been telling the mom for probably a good 30 minutes, if not longer, that the baby was ready to eat. So we want to help mom to see these cues and to recognize them and to understand that we don't need to wait for the baby to cry to feed the baby. Entertainment. So what are we doing with entertaining babies? Newborn babies just want to look at and hear their parents' voice. Babies will respond to dad's voice, to mom's voice, to siblings' voice. So that's going to be the most important thing for the first few days, is just in letting the baby hear their family and be close to their family. Remember, their sight is developing and they can only really see from about the breast to mom's face. So we want everybody to get in there and get close and be able to, for the baby to be able to see them and hear them. And we need to consider the entire family when we're talking to the mom and the dad about adjustment and readjustment. For the dad, for the father, transition to parenthood, it's a developmental transition in a time of disorder and disequilibrium. His normal coping methods might not work, and we want him to be aware of that so that he can either reach far in and find different coping methods, or at least understand that it's okay that his coping methods aren't working. For the teen mom, we're going to see a lack of knowledge and maturity. She might not be quite as verbal with the baby. So we want to provide far more education. We'll probably provide a social work consult and teen mom support groups so that she can help work through some of those things. AMA is going to be our advanced maternal age moms. And here we have the problem of kind of a sandwich generation. So we have mom who maybe her parents have died already, and she doesn't have the familial support or potentially the social support even. Her friends may be dealing with their own kind of growing kids, and they're not in the same place that she is in. She's going to potentially have conflicts over work because she's been able to work up until this point and has an established career and expects to be able to continue that most of the time. And sometimes it's just not possible. She's going to experience far more fatigue and a significant lack of energy than a younger mom is going to experience. It was kind of interesting. I went to a friend of mine from high school's baby shower a couple weeks ago, and she is almost 40, having her first baby. And there were probably, 20 women at the shower. And it was an interesting social environment for me because I have 3 children, and they're not babies anymore. And I was one of 3 women under 60 there who had kids. The majority of my high school friends' current social support system do not have children, and they're older. they're not planning on having children. They're either past the point where they would have children, or they're, mid-30s without children, which is fine. I'm not judging that decision in any way, shape, or form, trust me. But it was interesting for me to be there. And then I realized, well, I guess if you're in a place to where you're mid-30s and you don't have children, your friends are mid-30s and they don't have children. And so that is going to have an impact on the support that these moms who are having babies in an advanced maternal age, which, remember, technically is anybody over 35, it's going to impact their support system because they don't have a lot of friends who are going through the same thing when they are. So for instance, although she's a good friend of mine, I'm not going through the newborn stage right now. My kids and my challenges with my children are very different than what she's going to be experiencing. And she has other friends who don't have children and don't know it. So it's kind of isolating in a way. With siblings, whenever we introduce a new baby, mom's going to be focusing on that baby. And so the siblings could potentially get jealous depending on their personality and depending on their temperament. And that's something we want mom to be aware of beforehand, and making sure that the siblings and the jealousy are dealt with, and potentially not allowing the siblings to be alone with the baby if it is an issue. Grandparents, they might care for the baby depending on the culture, and they might have a tough time with the parents' desire for autonomy. So bringing these things up and just asking, what's your plan for your family? What's your plan for childcare? What's your plan for the siblings at home? What's your support system at home? These are all good questions to ask so that mom can start thinking about these things so they're not quite as much of a shock when they come up. Okay, so now we're going to move on to some complications that occur in the postpartum period. PPH refers to postpartum hemorrhage. This is the leading cause of maternal morbidity and mortality worldwide. Significant. Risk factors include anything that stretches the uterus out, retained fragments, or causes a laceration. We're going to see different types of blood, and the different types of blood we see could indicate what the problem is. So for instance, venous blood is dark. We might see that with varices or superficial lacerations of the birth canal. They might see a slow trickle, so oozing, or frank hemorrhage. If it's bright, it's going to be arterial blood, and the bright red blood is potentially a result of deep lacerations of the cervix, in which case the mom would need to go to the OR to have that cervix repaired. We might see spurts of blood with clots, and this might have to do that there's placenta left. So that would be retained placental separation, or retained placental fragments. With inversion, we can see spurts of blood as well. And one of the ways that we hope to avoid a uterine inversion, which is very scary when it happens, is that the provider hopefully is not tugging on the cord to deliver the placenta. So most of the time they'll pull gently, and as the uterus involutes, it comes down further, and the placenta should separate on its own. We do not want the provider pulling on that. Now, at the same time, we're not necessarily dictating that to the provider, although we can gently suggest that they stop pulling on the cord. With uterine atony, we're going to see the hypotonia of the uterus, and like we discussed earlier, we're going to be rubbing that fundus to bring that uterus down. With the atony, we're going to see more of the venous blood that's coming out. We might see a mixture of the venous blood and the arterial blood, depending on how long it is after birth that we are experiencing the atony. Vaginal hematomas occur with forceps sometimes, or with episiotomies. They're not very they're not very common, but they can be dangerous because the woman could bleed pretty significantly into that hematoma. So we want to be assessing for them and be aware of them. She's going to present as constant pressure or pain in the pelvic area. This is a flow chart of what we're looking at when we experience a postpartum hemorrhage. So first we're going to assess to determine the source of bleeding and make sure we're not having any signs of shock. We're going to anticipate lab studies. So you can already see that we're going to need somewhat of a team to be present if we have a postpartum hemorrhage situation. We want to make sure that we have venous access. And if we think we're going to have a significant hemorrhage, if we think a significant hemorrhage is occurring, we'll typically throw a second line in before she loses too much blood, and we're not able to, and with the anticipation of administering blood. So you can see we can have retained placenta, or a coagulopathy problem, or if our placenta delivered and we still have issues, what's the problem? So this is a great chart to go through and just kind of walk through the process of what we would do in these various situations of that cause postpartum hemorrhages. So some of the nursing interventions, like we've talked about, are fundal massage, and we want to make sure that we're adequately supporting that lower uterine segment so that we don't prolapse the uterus. We're going to straight cath mom potentially so that she can, if we think that her bladder is full, if we can palpate her bladder at all, we're going to straight cath her. And if we're going back to the OR for anything, then we're going to actually put a Foley in so that she has that Foley catheter in. We're going to give her an IV bolus. We'll probably utilize Pitocin in that IV bolus to help to contract the uterus. And we'll usually flow in probably between 500 and 1,000 mLs. That also helps by increasing her blood volume. We're going to administer some medications. We're going to look at Methergin, Hemabate, Cytotec, and the newest medication we're utilizing is tranexamic acid. Methergin we give as an IM shot. It's given in the thigh typically. However, it cannot be given to any hypertensive mother because it's going to increase her blood pressure. So if we have a mom with PIH or preeclampsia, or who has just had an elevated blood pressure through her labor, we are not going to give Methergin. It's a contraindication. Hemabate is contraindicated for anybody with a history of asthma. Hemabate is also given via sub-Q. It's an injection as well, typically sub-Q. Cytotec is given rectally, and I want you to think about why it's given rectally. I'll tell you in a minute, but be thinking, why would we give it rectally and not vaginally in a postpartum hemorrhage situation? And tranexamic acid is administered via IV, and it really helps to prevent the bleeding and helps to treat the hemorrhage. It's been a fabulous medication added to our postpartum hemorrhage arsenal. Back to that Cytotec. Why are we placing it rectally, not vaginally? Well, if mom is hemorrhaging, she has significant amounts of blood coming out of her vagina. So if we place the medication in there, the likelihood is it's just going to flow out with the blood. So it's going to be placed rectally so that the body can absorb it. Our last sign is going to be surgical, or last step would be surgical interventions. So if it's cervical laceration, they're going to have to go back to the OR to repair that. If there's retained placenta and they're not able to adequately clear out the uterus in the labor room, we're going to go back to the OR. If there's bleeding and we just don't know what it is, we're going to go back to the OR. The worst hemorrhage that I've been a part of, it was we were in the OR for well over 8 hours, and mom survived. She did end up with a hysterectomy, and it was one of her splenic arteries ruptured during a vaginal birth. So crazy things can happen. So we need to be on the lookout for hemorrhages that occur for all sorts of different reasons. We are going to watch our clotting factors to make sure that our mom is not going into DIC. And we want to make sure that we have adequate analgesia or anesthetic on board so that she's not in pain in addition to losing all of this blood. We also are going to potentially be ordering blood. We have what are called massive transfusion protocols in almost every hospital I've been in the OB world. And we have rapid infusers that literally push a unit of blood in about a minute. So it kind of throws all those blood administration protocols out the window, but when she needs blood because she's losing it so quickly, we have to replace that blood volume. And we're able to do so very quickly with the rapid infusers, which is awesome. So we're also going to look out for shock. What is the first sign of hemorrhagic shock? Think about it for just a second. It's going to be tachycardia, right? Because the heart is trying to compensate for the loss of blood, for the loss of blood pressure and the loss of blood by beating faster. So the first sign that we're going to see is going to be tachycardia. So moving on from postpartum hemorrhage to thromboembolic disease. So 1 in 1,000 to 1 in 2,000 women will experience thromboembolic disease. We have decreased this rate significantly because we've started to encourage early ambulation, even with our C-section patients. We want them up and walking as soon as their legs will hold them. What puts the postpartum woman at risk of this is the venous stasis, the state of hypercoagulation after birth. If she has an operative vaginal birth, so that would be the forceps or the vacuum. If she has a C-section, if she's obese, advanced maternal age, infections, smoking, these all put mom at risk for having this thromboembolic disease. This is a picture of a mom with a DVT, and you can see that her left leg is far more swollen than her right leg, which is an indication of the DVT. We might see a PE, an SVT, or a DVT. For the SVTs, we're going to prescribe or give NSAIDs, help her to understand that she really needs to rest. We're going to do elastic stockings and some heat application. For DVTs, we're going to do an anticoagulant. So we'll give her IV heparin for 3 to 5 days, and then she'll go on warfarin for 3 months after that, potentially injections as well. If mom experiences this and ends up on a long-term anticoagulant therapy, then there's some complications that occur when she gets pregnant again, and they relate to the epidural. And in fact, the last time I worked at Kaiser, we had a patient who had taken her heparin at home, and she was on a higher dose, so she was taking more than 10,000 units. And I think her dose was like BID, but she had taken it at 10 p.m. She came in labor about 2 a.m. she wasn't going to be able to get the epidural till 10 p.m. that same day, but it had to be 24 hours after the administration of the heparin, because of the risk for bleeding that puts her in when she's on the heparin. So that's could be significant for her. I don't know how it all turned out, but I know we started a fentanyl drip for her so that she could have some pain relief in labor, but she probably ended up delivering without an epidural, which was not her desired birth plan. So just kind of an interesting caveat to that continued anticoagulant therapy. Endometritis is another complication. It's the most common cause of postpartum infection. It usually starts as a localized infection at the placental site, but it can spread to the entire endometrium. We're going to see a fever higher than 38 degrees Celsius, which is 100.4 Fahrenheit. We're going to see uterine tenderness and foul-smelling lochia. So we always want to tell our moms if they spike a fever or if something doesn't smell good that's coming out of them, they need to go back. They need to go to their doctor and get checked out. Hopefully nothing was left inside, but that could be the reason as well. So these mamas we're going to put on a broad spectrum IV antibiotic to treat this endometritis. Mastitis. So mastitis is going to affect 1 to 10% of women soon after childbirth. And you can see here that the left breast is reddened and a little bit more swollen than the right breast here. It's almost always unilateral, and it's usually well after the milk has been established, so 2 to 3 weeks after birth. Generally, it's Staphylococcus aureus, which is causing this infection. An infected nipple fissure can rapidly progress into a breast abscess. So that's why it's important that we ensure the adequate latch of the baby, make sure that there's no nipple trauma occurring, and that if mom has a clogged milk duct or something that presents as mastitis, that we're treating it very quickly. We're going to support her breasts with heat and cold therapy and provide antibiotics to her. She might end up on IV antibiotics if it turns into an abscess, but most likely we can treat it with just oral antibiotics at home. We want her to continue feeding her baby. That's really going to help her progress through this, is just continuing to feed that baby, because that moves the milk. And the infection is actually around the milk ducts. It's not inside the milk duct, so the milk is not infected. The only time mom should stop nursing is if she's septic. So if she has, she's an infection of her blood, her entire body, then we're going to want her to stop nursing because she can pass the infection to the baby. But localized infections do not pass to the baby. So this is our last topic for postpartum complications, and this is our psychiatric conditions. So remember, back to our bubble heat, and the last thing we assess and talk about is emotions. And here are some of the talking points for this and some of the more pertinent information surrounding that. So postpartum blues is completely normal. It affects 50 to 80%, probably closer to the 80% of all women who have a baby. They're going to cry for no reason. They might feel a little bit of depression, letdown feelings, restlessness, fatigue, insomnia, headache, anger, anxiety, sadness. Totally normal for the first couple weeks after pregnancy. They're experiencing emotional and physical vulnerability and being overwhelmed. They're sleep deprived. They're in pain. They're dealing with the sole responsibility of keeping this little baby alive. Even if they have a lot of support at home, especially those breastfeeding moms, exclusively breastfeeding, it's their job to feed this baby, and that can be a lot of pressure. And we want her to continue to breastfeed if that's what she wants to do, but it still is a lot, especially for first-time moms. So there's a significant swing in hormones that occurs as well, which contributes to this postpartum baby blues. When we move into postpartum depression, this affects 10 to 15% of all women. And it may be related to biologic or psychologic or situational causes. It's really multifactorial. If she has a personal or family history of a mood disorder, there might be a higher risk. And it's postpartum blues, signs and symptoms that last past the first few weeks. So if we're into like week 4 and mom is still experiencing those postpartum blues, signs and symptoms of crying for no reason, feeling depressed, let down, restless, significant fatigue and insomnia, headache, anxiety, sadness, anger. If she's still experiencing those things past week 3 would be kind of the ultimate cutoff, then we're going to consider postpartum depression. And that's what we want her to be aware of, that some of these things are normal to experience for the first few weeks, but if they continue on, we want her to call her provider. With depression, the distinguishing feature is irritability, the rejection of her significant other or baby. So if mom isn't caring to care for her baby, that's a red flag. And that's where we really want the significant other to be present when we're having this discussion. Because if he is feeling or she is feeling dismissed by mom and feeling rejected by mom, that should not be a emotional trigger for them. It should be a red flag for that significant other that they need to refer this mom for help from their provider. Usually there is a gradual improvement about 6 months after birth, but a lot of the time we really want these moms on antidepressants and anti-anxiety medication. We might consider counseling for her as well, and in some cases ECT can be effective as well. Having a support system and having like support groups in place can really help to prevent the onset. And with early treatment, these moms can continue to bond and have that attachment with their baby that they might not otherwise gain if they don't receive treatment for postpartum depression. Postpartum psychosis is similar to depression with a few added components. Mom may experience delusions and thoughts of harming herself or the baby. So in postpartum depression, she doesn't want to harm the baby. She just doesn't really want anything to do with the baby. She will still diaper it, feed it, but she's not going to snuggle and sit there and coo towards the baby. She's not going to think the baby's cute. She will provide for its basic needs, and that's about it. Postpartum psychosis, she might want to harm the baby or her significant other or herself. Patients are typically agitated, overactive, confused, complaining, or suspicious. Postpartum psychosis is a psychiatric emergency, and this mother needs to be referred to a hospital. And she might not be encouraged to breastfeed just so that she can establish a separation, so that she can reestablish a bonding and attachment to the baby. The postpartum psychosis moms, those are the moms who load up all their kids into a car and drive off a bridge because they're not in their right mind. So we want to have these discussions with our moms when they're in the hospital with us, hopefully in the presence of their significant other, so that they know the warning signs as well, because we have fabulous outcomes when we treat early for postpartum depression and we don't advance to postpartum psychosis. It's not if you have depression and don't treat, you advance to postpartum psychosis, but you don't go from postpartum blues to postpartum psychosis. There is a little bit of depression in there before hitting the delusional aspect of it. Always end on such a happy note. But here's my cute little Abigail when she was just a tiny little thing. So that is the end or new beginning, based on how you look at it, of the Postpartum and Postpartum Complications lecture. I hope you've written down any questions you have, and we will talk about those at the beginning of our next in-person lecture.